Okay, so all right, so I welcome you all to this discussion on the INI SS Neurosurgery November 2023 recall. So in this session, we'll be discussing those neurosurgery questions which were asked in that in the last INI SS exam. So this is to help us recall and make sure that we don't make mistakes if the same question or a very similar type of question gets repeated. So with this brief note, I'll take you through the questions. So the first question there was, and before I even begin this session, I would like to thank my students who have contributed to this INISS recall very much. In particular, Dr. Srinivas Tate, who has joined in Patna, and he got rank 8 in the INISS neurosurgery exam. And I sincerely thank him for his efforts in giving us these questions. And this it is because of him and the compilation that he has made, which has helped us in putting out this video. So my sincere thanks to him. So with this brief note, I will now begin the session. So the first question was center for vertical gaze. The center for vertical gaze, option A, PPRF, option B, posterior commissure, option C, rostral interstitial nucleus of Kajal, option D, posterior commissure and rostral interstitial nucleus of Kajal. So the answer is both the posterior commissure and the rostral interstitial nucleus of Kajal. So both the RMLF, the interstitial nucleus of Kajal, and the posterior commissure, all these will play a very important role, and they are considered to be the brainstem centers for vertical eye movement. So the answer is option D. So the next question that was framed was identify the spotter, that is the asterisk that has been marked in the image. In a CT image, they had marked the internal capsule, and in that internal capsule, what they have marked is actually the genu. So that was the question that was asked. So the asterisk that has been marked here is the genu. So genu was the answer for this question. Then the band of Giacometti is presented. Is it option A, temporal lobe? Option B, mesial occipital lobe. Option C, cingulate gyrus. Option D, frontal lobe. So this is a new question. The band of Giacometti is present in the temporal lobe. So what is this? This is actually the tail of dentate gyrus or the limbus Giacometti, and it is in the anteromedial continuation of the dentate gyrus. So all this will be a part of the hippocampal formation, which is there in the temporal lobe. So along with the hippocampus, subicular complex, and the entorhinal cortex, this will form the hippocampal formation. So the answer will be the medial part of temporal lobe, but as here it is going to be the temporal lobe. That is the answer for this question. Median survival GBM. So this is asked time and time again, and despite the best of the advances in medical sciences, GBM has been very difficult to treat, and the median survival is less than a year. That is around 10 months. Even with radiotherapy and temozolomide, the median survival rate remains to be around 10 months and up to 14 months. So the right answer would be 1 year. So option A would be the answer, even in those patients who receive combined treatment of radiotherapy and chemotherapy. The next question is on spinal meningioma. Spinal meningioma, common age group, is it option A, first and second decade? Option B, second and third decade? Option C, fourth and fifth decade? Option D, fifth and sixth decade. So now, this is a little bit tricky because the classical description for a patient with a spinal meningioma is actually a woman. It's actually a middle-aged woman. Yes, right. It's actually a middle-aged woman. But contrary to what is being classically being described, it has been found that the incidence is higher between the sixth and the eighth decade actually. So the answer here of all the pick, I would go with option D, which is the fifth and sixth decade. But spinal meningiomas are quite rare tumors that derive from meninges in the spinal cord and represent around 25 to 30% of all intradural extramedullary lesions. So they can grow anywhere along the spine, but the most frequent site is the thoracic spine, and the peak incidence is the sixth through the eighth decade. So because of this, I would go with option D. Now, the next question was to spot the location of the lateral corticospinal tract. So the lateral corticospinal tract lies somewhere. I'm using a marker here. See, you consider this to be the equator of the spinal cord. That is where the central canal is. You consider this to be the equator where the central canal is. So the lateral corticospinal tract will be located posterior to the equator. Will be located posterior to the equator. This is where the lateral corticospinal tract usually lies. So this would be the location of the lateral corticospinal tract. So this again is a very tricky question. All right. All right. So the next question, a female complaining of decreased vision. A female complaining of decreased vision. Okay. Give me a minute to organize this. Okay. A female complaining of decreased vision, papilledema, MRI orbit is being done. So what is the diagnosis? So here, what we can see that the left optic nerve, there is going the left optic nerve is showing. This is the left optic nerve, and you can see here the optic nerve is showing some enhancement with the contrast. So this is classically, say, any lesion that arises from the optic nerve. Optic nerve is nothing but continuation of the white matter tract. So it is going to be an optic nerve glioma, which usually arises from this location. It is a optic nerve glioma, not an optic nerve meningioma. Okay. Why? Because glioma, the optic nerve, it's a white matter tract. So it is going to be a brain, it is going to be an intraaxial brain tumor that grows out through that and not an extraaxial lesion. So if it were to be an optic nerve meningioma, if at all it's going to be an optic nerve meningioma, then the nerve would actually be compressed. It is not going to arise from the nerve. It is going to compress on the nerve, so it will be thinned out. You don't get a thickened or a widened optic nerve. So this is classically a optic nerve glioma. A patient presents with features of acromegaly, bitemporal hemianopia, and the hormone panel is showing a elevated growth hormone level. MRI is showing a pituitary microadenoma, pituitary macroadenoma. So what is the treatment? So for all pituitary tumors other than prolactinoma, the treatment is going to be a transnasal transsphenoidal surgery. It is only prolactinoma where the tumor responds very well to bromocriptine and cabergoline, or even acromegaly does respond to bromocriptine, but it is always better to do a transnasal transsphenoidal surgery rather than put them on a therapeutic medical management with bromocriptine. So best answer here would be transnasal transsphenoidal surgery. In fact, this is the only tumor in the entire brain where you can go on to put them, you can treat them with a medical management, despite that being a tumor. So that would be prolactinoma. For all other tumors, it is going to be surgery. And in this case, in an acromegaly, again, it is going to be surgery. Following delivery, a female had breastfed her child for 1 year. 2 years later, patient is having amenorrhea for the past 6 months. Patient is diagnosed with brain tumor. Doctor said the patient only needs medical treatment. So what is the diagnosis? This is classically a picture of a prolactinoma. So amenorrhea, first thing you have to remember, after ruling out all the gynecological causes, you should always keep in the back of the mind that it could be a prolactinoma which is responsible for the amenorrhea. And since the patient is diagnosed with a brain tumor, it is most likely to be a prolactinoma, a true prolactin secreting tumor, which is going to increase the prolactin levels, that is going to cause the amenorrhea galactorrhea syndrome. And in that case, it is enough to treat them with a medical treatment as such. That is the bromocriptine or cabergoline. So that is more than enough for these patients. The answer is prolactinoma. Question number 10. A 30-year-old male presents with headache and diplopia. On examination, is found to have difficulty in near vision with nystagmus on attempted near vision with lid retraction. What is the possible location of the lesion? This is a tricky question. He's having headache, diplopia. He's having difficulty in near vision with nystagmus. So this is classically the description of the convergence retraction nystagmus, which happens in pineal region tumor. It happens in pineal region tumor. So most commonly a pineocytoma or pineoblastoma is going to be there, or even a germ cell tumor, because germ cell tumors are quite common in the pineal region. Both EMG, that is the electromyogram, and the nerve conduction study are useful in the diagnosis of, is it option A, carpal tunnel syndrome, option B, trigeminal schwannoma, option C, slipped lumbar disc? The answer here is carpal tunnel syndrome, because there is no point in doing a EMG for a trigeminal schwannoma, because you will naturally identify EMG, NCS, all this, they work for the peripheral nerves. So it could either be option A or option C. But again, I would like to lean towards option A, because electromyogram is generally diagnostic to determine and rule out the evidence of axonal damage through the presence of fibrillation action potentials or positive sharp waves. And the abductor pollicis brevis is the muscle that is frequently tested for this. And a conduction block along the carpal tunnel demonstrates the absence of fibrillation potentials and sharp waves, but decrease the recruitment of abductor pollicis brevis. So hence, I would like to go with EMG and NCS being done for the carpal tunnel syndrome as the answer here. The next question, not a feature of neurogenic shock. Some of them told it was spinal shock, some of them told it was neurogenic shock. But anyway, spinal shock and neurogenic shock, they frequently coexist with each other following spinal cord lesion above the level of the T6 level of spinal cord. So what are the features? Tachycardia or bradycardia with hypotension, decreased spontaneous venous return with increased venous capacitance, or option C, can be seen following cranial, spinal injuries and high spinal anesthesia. Option D, phenylephrine is the drug of choice in management. So the answer here is going to be phenylephrine, because phenylephrine is not useful in managing patients with neurogenic shock. Rather, spinal shock is nothing but complete loss of neurological function, including reflexes, sensation, and rectal tone below the level of injury. So what happens here is it's a transient physiologic reflex depression of the cord function below the level of injury. So all the motor function, sensory function, and reflexes below the level of injury is lost. So flaccid paralysis, including bladder bowel involvement, and these tend to last for several days to several hours to few days until the reflex below begins to function again. So the first reflex to begin to recover is actually the bulbocavernous reflex and the muscle stretch reflex later on. So the answer here would be phenylephrine. Phenylephrine is not useful in managing patients with a neurogenic shock. A teen female presents with loss of consciousness and a DSA image like the one that is given here had been given. So what is the diagnosis? So this is classically an AVM. You can see here the DSA, it is showing you the arterial phase and the blood going into the nidus, and then even the veins, draining veins even you can see. So this is classically an AVM. It's classically an AVM. Majority of the questions were actually from the notes and from the videos that we have done. So it is actually a straightforward paper when you take neurosurgery assess. A 26-year-old graduate who worked as a cashier is caught with financial irregularities at his workplace. He denies telling lies about his financial records. He is found to have difficulty in telling right from left and misguides his friend and employer to his house. What is the possible site of lesion? So this was a little bit confusing, but whatever picture they have given here, it is actually the Gressman syndrome. It is actually the Gressman syndrome. So Gressman syndrome is where you get finger agnosia, right-left incoordination, agraphia, and acalculia. So he had financial irregularities mainly because of acalculia, and he is not lying. So he misguides right and left. So that is a clue given to you. So here the answer is going to be the dominant parietal lobe, as in here the left supramarginal and angular gyrus. So that would be the answer. So this question, I was able to get only one option, which is actually the answer. So what does the term task shifting in neurosurgery means? The term task shifting in neurosurgery means training general surgeons or other people of other non-neurosurgical specialty to do basic neurosurgery procedures. So that is what is called as task shifting. In some instances where the number of neurosurgeons are less or the cases are very high, then you will have to train general surgeons to do the basic neurosurgery procedures. That is what you call it as task shifting. So neurosurgical task shifting or task sharing is a process of delegating clinical tasks to non-neurosurgical specialists, such as general surgeons, general practitioners, or non-physician clinicians. So all this is called as neurosurgical task shifting and task sharing. Downbeat nystagmus, question number 16, is not seen in. Is it option A, Arnold Chiari malformation, option B, meningitis, option C, posterior fossa tumor, option D, foramen magnum meningioma? The answer is meningitis. So what is this downbeat nystagmus? Downbeat nystagmus is characterized by pathological upward drift of the gaze, followed by corrective downward saccade. So it is most apparent when the patient is asked to look down, and it is typically accompanied by oscillopsia, which can be severe. So it is usually due to structural pathology at the cervicomedullary junction, as in the Arnold Chiari malformation, or a spinocerebellar degeneration, which is accompanied by a positive family history. Okay, so the answer is going to be a pathology involving the cervicomedullary junction. So as in this case, the Arnold Chiari malformation, posterior fossa tumor, all these are going to be there. Foramen magnum meningioma, in everything is happening at the cervicomedullary junction, whereas meningitis is not related to that. So that would be the answer. Following is contraindicated in Atlanta axial dislocation. This question, despite the best of the way that it has been framed, I'm not very sure what exactly was the option C was. Because passive flexion and extension exercises, you have to do it for the limbs. Active flexion and extension exercises, again for the limbs, you are supposed to do. I don't know what brace was given there, but the answer option D was hollow wrist. So what is contraindicated is something like you need to immobilize the occipitocervical or the C1, C2 junction. So in that case, a hollow wrist is very much needed. So probably another Philadelphia brace or a soft brace was being given in the answer, which is not true. So I would like to go with answer C. Investigation of choice for transverse ligament tear. Transverse ligament tear is a very, very, very important topic. All the C1, C2, Atlanta axial, AAD, or the C2 fractures, all these are very important questions which have been asked time and time again. So investigation of choice for transverse ligament tear. So the answer is going to be MRI brain. MRI CVJ. MRI CVJ will show you injury to the ligament, and that is where you have to rule it out. Because if there were to be an incident, if there were to be a C2 fracture, and you are going to and you are planning to do a odontoid screw, but you identify that the patient is having a transverse ligament injury, then you go on to do a C1, C2 fixation rather than putting a odontoid screw. So that answer would be option A. Surgery for Lennox-Gastaut syndrome, it is going to be corpus callosophy. This again is a straightforward pick from the notes. Stereotactic radiosurgery is used in, I believe the question is all except, because it is used in high-grade glioma. It can be used in cavernoma, though it is quite resistant, but it can be used in cavernoma. But where it cannot be used is going to be the intracranial berry-aneurysm. It is not useful in intracranial berry-aneurysm. So if the question is going to be all except, then I would like to go with intracranial berry-aneurysm as the answer. But if you were to mark one, because I'm not very sure how exactly was this question framed. So if the question were to be just plain like this, then I would mark option A, because SRS is useful in induction in high-grade gliomas. But again, it is useful in cavernomas even, despite the fact that they being low flow, low pressure lesions, they respond very well to stereotactic radiotherapy or radiosurgery. But it is not useful in treating intracranial berry-aneurysm. So if the question did not have an all except, then I would go with option A. But if the question had an all except, I would like to go with option C. Lesion involving cerebellar peduncle, 7th cranial nerve, 8th cranial nerve. Lesion is at cerebellopontine angle. This is classical vestibular schwannoma. Lesion involving the 8th cranial nerve, 7th cranial nerve, and the cerebellar peduncle. It is going to be a vestibular schwannoma. The answer is option A, CP angle. Not a component of Horner syndrome. Horner syndrome, you have meiosis rather than mydriasis. Enophthalmos, anhidrosis, loss of celospinal reflex, all will be there. So the answer is option D. Incorrect statement about brain death. Absent brainstem. What is brain death? You all know brain death is nothing but when the brain stops its function and depends on ventilator and inotropes for the function of the lungs and the heart. So that is what you call it as brain death. So how are you going to determine brain death? You are going to demonstrate that the patient is not having brainstem reflexes and is not able to take a breath. So option A, absence of brainstem reflexes for a specific period of time. That is true. Option C, apnea with the PCO2 level of more than 60 for 10 minutes. That again is true. What is not true is EEG and intracerebral angiogram. It is not a must. It can be done. It is supposed to be an auxiliary test. It is not like it is a must to be done test. Okay. So the answer is option B. Distance between the patient and Snell's chart. The answer is 20 feet. The answer is 20 feet. L4, L5, far lateral disc bulge. This is again one of the favorite questions. Muscle weakness is seen. So L4, L5 level, the exiting nerve root will be L4. The traversing nerve root will be L5. In a far lateral disc, it is the L4 nerve root which is going to be affected. So that is going to involve the foot inversion. So tibialis anterior and EHL produce dorsiflexion and inversion of the foot, which will be affected when there is a far lateral L4, L5 disc collapse. So it's a very important question and I have explained it to you in detail in the videos. Not a branch arising from the root of the brachial plexus. So it is the nerve to subclavius. Other than that, the dorsoscapular nerve, the long thoracic nerve of Bell, and the nerve to rhomboid, all these will arise from the root of the brachial plexus, whereas the nerve to subclavius does not arise from that. Most common cause of post-surgery discitis. So you would be tempted to mark staph epidermidis here. Okay, so the answer is actually Staph aureus. It is not staph epidermidis. So don't be tempted to mark staph epidermidis as the answer here. It is still a staph aureus, which is the most common cause of even in post-surgery discitis. Most common brain tumor in middle-aged HIV patients is going to be is it option A, GBM, option B, medulloblastoma, or is it option C, lymphoma? The answer is option C, lymphoma. If it were to be the most common SOL in the brain in a HIV plus patient, then the answer, if the answer had toxoplasmosis, then it is going to be toxoplasmosis. Space occupying lesion as such is going to be toxoplasmosis. If they have given brain tumor in the answer, then it is going to be a brain tumor. In that case, it is going to be lymphoma. Okay. Clinical scenario, a child with hydrocephalus, MRI showing you intraventricular lesion with phlovoids. What is the possible diagnosis? Is it option A, ependymoma? Option B, SEGA, that is the subependymal giant cell astrocytoma, which is a tumor which you identify it in association with the tuberous sclerosis. Or is it option C, choroid plexus papilloma? Or is it option D, medulloblastoma? So this characteristic intraventricular lesion with phlovoids, I would like to go with option C, that is the choroid plexus papilloma as the answer. Marker for astrocyte tumor. It is very straightforward. Glial fibrillary acidic protein. So GFAP is the marker for astrocyte tumor. Term removed from WHO classification. Probably they knew the answer, so that is why they have given only option A, that is the gliomatosis cerebri. There is no longer a term called gliomatosis cerebri in the recent WHO classification. Artery of Bernasconi and Casanari is a branch arising from, is it option A, inferior hypophyseal artery, option B, in ICA, option C, ACA, option D, MCA. Artery of Bernasconi and Casanari, the best option here is ICA. So it is around 2 centimeters long and it arises from the meningohypophyseal trunk. That is going to be the C4 segment. Originating from the C4 segment of the ICA, it runs along the tentorium. It is usually a single trunk and it supplies the meninges of the tentorium cerebelli, the oculomotor nerve, the trochlear nerve, and the abducens nerve. So here the answer is going to be ICA. ICA segment, that is neither intradural nor intracranial. Is it option A, cavernous? Option B, carotid bifurcation? Option C, ophthalmic segment? Option D, communicating. So all these are actually intradural and intracranial, except the cavernous segment, which is going to be interdural. It is going to be interdural. Posterior cerebral artery P1, P2 divided by which anatomical structure? You know, it is straightforward. It is going to be the posterior communicating artery. So that is where the anterior and the posterior circulation is going to be communicated by. Artery of Petron infarct, this has been asked around third, fourth time in the INI SS paper. So this is a very, very, very important question. So it is going to be artery of Petron infarct. It will be bilateral thalamic and midbrain infarct. Artery of Petron is a variant of the posterior cerebral circulation. It is characterized by a solitary trunk that supplies blood to the paramedian thalami. So bilateral, both side paramedian thalami with the rostral midbrain. So that will be the artery of Petron. So what happens when there is an infarct here? So it is going to end up with the classical triad of altered mental state, altered mental status, supranuclear vertical gaze palsy, and memory impairment. So this is the characteristic presentation for this artery of Petron infarct. So this is very important, and you have to make sure that you don't make a mistake here. So question number 36 had been a spotter of a child with a head swelling, past history of closed linear fracture managed conservatively about a year ago. So now she has come with complaints of slowly increasing swelling since 2 to 4 months. So what is the diagnosis? So earlier there was a term called growing skull fracture. So the answer is actually a craniocerebral erosion, which is again the other new term for growing skull fracture. It has been recently termed as craniocerebral erosion. So what is a growing skull fracture? A growing skull fracture is a rare complication of skull fractures seen mainly in infancy and early childhood. So what happens here is progressive diastatic enlargement of the fracture line. So this is a late complication, and it is also known by the term leptomeningeal cyst because of its frequent association with the cystic mass filled with CSF. So what happens is due to the fracture, not only there was the fracture, but there was also a tear in the dura. So through that, the CSF had actually managed to seep out, and the fracture actually grew, so not allowing it to heal. And because of that, the pulsatile dura can frequently be seen between the edges of the fracture. So because of that, it looks like it looks as if the fracture has grown in size. So that is why you call it as a growing skull fracture. Okay. So the answer here is going to be craniocerebral erosion, which is a new term for growing skull fracture. Okay. So the other term is actually leptomeningeal cyst, which you have to remember it with. Not a feature of pyramidal lesion. So pyramidal lesion is nothing but the corticospinal tract involvement that is going to present to you with clonus, Babinski sign, and Hoffman sign. Everything will be positive, but not globular tap. Globular tap is actually a frontal lobe release sign. So that is not a pyramidal sign. Pyramidal sign means anything that is related to the corticospinal tract. That is what you call it as a pyramidal lesion. Frailty in neurosurgery. This is a new question. Frailty in neurosurgery is actually a very new concept. Which of the following is not considered as a feature of frailty? This is actually a general concept. Frailty means a patient is very much dependent on something, and it need not be related to a low hematocrit level. Okay, it could be osteoporosis, it could be past history of more than 2 falls in 6 months, it could be decreased cognition, but it has nothing to do with a less hematocrit. Okay, I'll explain to you what frailty is. 3 out of 5 phenotypic criteria have to be met. One is low grip strength. So because of that, they have a tendency to fall. Low energy, slow walking speed, low physical activity, and unintentional weight loss. So all these are the characteristic features to call them as frail. Frail means weak. So low grip strength, low energy, slow walking speed, low physical activity, and unintentional weight loss. So all these are characteristic features of the frailty. Okay. A patient underwent the following surgery. What must have been the clinical symptom prior to the surgery? So here, if you can see, it is a lateral X-ray of the cervical spine. And if you count from above below, it is actually the C6, C7 level. It is actually the C6, C7 level. So I'll count it for you. So this will be C1, this is C2, C3, 4, 5, 6, 7. So there is a C6, C7 fixation. So C6, C7 fixation had been done. So probably the patient had a disc lesion there. And the C6, C7 level, it is going to be the C7 nerve root which is coming out. So if it is going to be the C7 nerve root, it will be triceps weakness and weakness of wrist extension. So that would be the answer for this question. So it is actually the C7 nerve root. This is very tricky, but you have to know from C5 to C7. You have to know all the nerve roots or the functions of each of these C5, C6, C7. You have to know, and similarly in the lumbar you have to know L4, L5. So both these are usually the questions that that has been frequently asked. Dermatome for little finger will be C8. So the middle aspect of the forearm will be C6. The middle of the forearm to the hand, it is going to be C7, and the dermatome for the little finger is going to be C8. The middle aspect of the forearm. The lateral aspect of the forearm would be C6. The middle aspect of the forearm and the hand would be C7, and the medial aspect would be C8. Antiepileptic effect, antiepileptic associated with elevated ammonia levels as side effect. So is it option A valproate, option B carbamazepine, option B phenobarbital? The answer is option A valproate. Valproate is the one that is associated with elevated ammonia levels. Hyperammonemia is a feature of that. Patient, you have to calculate the GCS now. So patient can localize pain, speak words which cannot be understood, and eye-opening to pain. See, there's no difficulty in getting the GCS of the eye opening and the motor response. So E is 2, motor response is 5. There is no doubt about that. The only problem here is the ability to speak words. So what is the verbal response? Verbal response, he speaks words which cannot be understood, meaning verbal responses is groaning to pain. So 5 is oriented speech. Verbal response 4 would be disoriented speech. Verbal response 3 would be inappropriate words. Again, that word will have a meaning. So if he is speaking something which you cannot understand, then the answer is going to be groaning or moaning to pain. So that is going to be V2. So the answer is GCS is E2, V2, and M5. So the answer would be 9. So I would go with answer option B, 9. Normal magnesium level is around 1.5 to 2.5 units. So 1.5 to 2.5 milliequivalents would be the answer for this question. Milligrams per deciliter. CSF rhinorrhea with indeterminate halo test. What is this halo test? You ask the patient to bend his head and you collect the CSF to find the halo sign. That is, the central one there will be that blood, and around that there will be a halo. So that is because of the CSF getting disseminated. So what is the best method to determine, to confirm that it is going to be CSF? It is going to be beta transferrin. You can close your eyes and mark transferrin as the answer because that is the confirmatory test to demonstrate CSF. So that would be the answer for CSF rhinorrhea. You are asked to calculate the volume of hematoma in radiology. A is the maximal diameter of the hematoma, B is the maximal width of the lesion, and C is the number of CT slices which have multiple hematoma multiplied. So what is the answer? So what is the formula to calculate the volume? The formula would be A into B into C, and you divide it by 2. So that is the answer. So maximal diameter, and you measure the maximal width of the lesion, and you measure the height of the lesion as well with the number of CT cuts, number of CT slices. That is how you measure the height of the clot. So you take all them, multiply them, and divide it by 2. You get the answer. Question number 46. What is this device used for? This is actually a head traction. This is actually a traction pin with which you skull tongue, which you use it to apply to reduce cervical fractures, or even while during surgeries, you will have to use this traction device to open up the disc space to fill it up with a bone graft or a metal spacer inside it. So this is going to be a cervical traction which is used in the C5, C6 disc collapse. That would be the answer here. That is option A. So it's actually a skull tongue. That is what this device is. So these are the 46 questions which I had managed to collect during the last exam. And I hope this session was useful to you, to those who are preparing for this INI SS exam. Be very confident in your preparation. Don't worry about the things which you have not read. Some of the questions can be very tricky, but majority of them would be something which you have already known. So if you have watched the videos or read or read the notes, you revise them again. You revise your notes again, and that is more than enough, because we have essentially had taken enough material from neurosurgical textbooks as such to prepare these videos and the notes and even the MCQs as such. So I believe this would help you in achieving your dream. And I request the ones who are appearing for this exam to do give the questions immediately after the exam, so that we'll be able to come out with the video and to help your juniors and friends in future as well. So on that note, I'm ending the session, and if you have any doubts, feel free to text me. And with that note, I'm ending this session. So if you have any doubts with you, I request you to do share them with me. Thank you.